Hello, everybody. On behalf of the American Diabetes Association, I want to welcome you to this really important discussion that we're really pleased that you could be part of. And really, what we're going to focus on is a really critical issue, and that is how we can prevent amputations. And so my name is Bob Gabay. I am an endocrinologist and the Chief Scientific and Medical Officer here at the American Diabetes Association. And I appreciate you all taking time away from your busy day for this critical conversation. Let me frame it with a few statistics for those that are less familiar with the issue of amputation and diabetes. So every 3.5 minutes, somebody in America loses a limb due to diabetes. And if that were not bad enough, here's the thing that really stuns me is that 80% of those amputations could be prevented. And that's literally why we're here today, to raise awareness, to talk about what can be done about this. And on top of those statistics, we also know that amputations disproportionately affect certain populations. And just as an example of that, when we look at communities of color, and particularly African Americans, they're twice as likely to have an amputation as whites. And so we're going to talk about what can be done about this. Where you live, sadly, also affects your risk of developing an amputation. Rural communities, um, communities in the southeastern part of the United States are also more likely to have amputations. So we very much here at the American Diabetes Association believe that every American with diabetes should have access to the care that we know can prevent the amputations from occurring. And that's why we launched an effort called Health Equity Now that has a series of Bill of Rights, one of which is what I just described, that everybody should have access to the care that can prevent an amputation. In addition, because this issue of amputation, unlike most complications of diabetes that have gone down over the years, amputations are actually on the rise. And so, all the more reason why we need to lean into this issue and shine a spotlight on it. And as a result, the American Diabetes Association established in 2022 the Amputation Prevention Alliance, and what we're doing here today is part of that. And what is that alliance? It is bringing together the community to address amputations by one, raising awareness for people living with diabetes and those that care about them, but also healthcare professionals, and then pushing the policy changes that are needed to ensure that the curve on amputations is not rising, but declining. And so you'll be hearing about this. And another thing that you'll learn about is we are releasing something we call a missed opportunities map, and it really looks at what are the opportunities where amputations can be prevented in the doctor's office, at home, and we'll be alluding to some of that. So I'm really pleased to have a really incredible group of individuals join us today for our panel discussion, and I'll have each of them introduce themselves and talk a little bit about what they do, and then we'll get into a discussion of questions around this. So I'm going to start with Michael. Who's a person living with diabetes, and Michael, if you want to just introduce yourself.
Yeah, as the little white thing says, Michael Resnick. I'm 68. I have had diabetes for 61 years. Um, I'm a practicing CPA and always have been, although I always question why. And I'm here based on discussions with my son and Chris, uh, that having gone through the process and touched upon a lot of different areas that actually lead up to the the ultimate amputation. and what the living with diabetes on some level is like.
So you've literally experienced what we're talking about, and that will really be helpful in informing the conversation. So thank you for joining us, Dr. Fife. Would you like to introduce yourself and say a few words?
Yeah, Dr. Bob, I'm honored to be here. Excited to talk about the Missed Opportunities Map. I've been practicing wound care for more than 30 years. I was trained and board certified as a family practitioner, and like lots of people who do wound care, fell into it, which might be part of the challenge we have in raising awareness because it's hard sometimes to find expertise. But I'm currently a professor of geriatrics at Baylor College of Medicine, and I also run something called the U.S. Wound Registry that does research on the effectiveness of different treatments for diabetic foot ulcers and other kinds of wounds.
Great. Then thank you for joining us, and we'll talk about the connection between how a wound can ultimately lead to an amputation and all the value of prevention. And Dr. Dove, why don't you introduce yourself?
Yes, my name is Dr. Sandy Dove, and I am very happy to be a part of this, especially as we have Dr. Fife here. I've been a fan of her publications for many years. I am the current director of clinical research at University of Texas San Antonio Health Science Center. I actually did my residency here many years ago in limb salvage. 20 years later, plus or minus a few years, I'm back directing clinical research, and it's alarming in 20 years that we have not decreased the rate of amputations. We've actually gone in the opposite direction despite all of the advances. So I think forums like this are essential to looking at where are we going wrong.
Great. Well, and thank you, Dr. Dove, for joining us and shedding light on that. And maybe I'll start with the first question, and maybe each of you might just give us your perspective. So, uh, why do many patients wait so long before they receive care for an issue, a wound or a problem with their feet? Dr. Fife, what's been your experience? Why the delay?
I think it's because diabetics don't have the gift of pain. That was one of the things we learned from the study of leprosy, a very famous book by that name. And it sounds maybe like a terrible thing to say, but if people with diabetes had pain in their feet, and if their diabetic foot ulcers or the early changes in their feet were excruciatingly painful, I bet we wouldn't have the amputation rate we have today, because people would be in the doctor's office saying, my foot hurts. But instead, the stories, I'm sure Dr. Dove can tell the same ones, of people who've burned the bottoms of their feet and only found out about it because they could smell their feet cooking and they didn't have any pain. So when you have a situation like that, it's going to be easy to miss unless you're aware that someone needs to look at your feet. And what diabetics also have, changes in their vision, which may make it very hard for them to see their feet. So if you don't have someone who lives with you who checks your feet, then things can be, I've seen people come in with bones hanging out and all they knew is that they had a little problem. So I would say, in my perspective, the lack of pain is a big contributor, although there are many.
Yeah, Dr. Dove, you see a lot of these situations and the painlessness of it, and maybe talk a little more about that.
Well, you don't know what you can't feel. There's no emotional connection to your foot. And as Dr. Fife alluded, if you have vision changes and you're older, and we know that diabetes causes central or obesity, a bigger belly, it can physically be hard to get down to actually look at your foot. And I do agree with Mr. Resnick. The male gender, I think Doctors Armstrong and Lavery pointed out that being a man is a risk factor. And I can tell you, with our service in the hospital at University of Texas San Antonio, predominantly most of our patients, it typically are male. So the male gender and neuropathy, it's not a great combination.
Yes,
In
that
other words, male gender you think is more of a risk factor. It's not just postponing care, but the
Yes.
male gender itself is a risk factor. That's interesting.
Yeah.
Dr. Bob, I was wondering, I don't know if we're supposed to ask you questions, but on the increasing rate of diabetes, is it because the prevalence of diabetes is going up? There are more people with diabetes, or are they living longer? Is it a strange side effect of the success of keeping people alive? And
that's a great question. It's some combination of those, but even when you factor in that there are more people with diabetes, it still seems to be increasing. And I think it really speaks to the lack of awareness and um, on the part of people living with diabetes, but also as we'll talk about, and you know a great deal about this, there are better treatments, and people are unaware, including healthcare professionals are unaware of the better treatments that are available, and so many times amputations occur when that could be avoided, even at the very late stage where you're in an emergency room and someone says, "Yeah, it's time to amputate." And maybe I could throw it back to you is so like yeah, why does that happen, or what like what should somebody do if they're told you need an amputation?
well, they need to ask for a second opinion. And I was just about to have Dr. Dove make some comments because, Michael's brought up a gender issue that may have to do with perspective. We've all got our perspectives, and there are lots of folks that may feel uncomfortable questioning the doctor. And so I think maybe Dr. Dove could speak a little bit to that because we have recent information that the place that she's practicing, San Antonio, has just got uniquely bad challenges in this problem.
And, unfortunately, that is very, very true. It can be somewhat disheartening, but I strongly believe that one of the things that we've missed is talking to our patients and giving them the power to know that they have tremendous power to direct the course of their care. If you feel frightened or you're afraid of the reaction of your doctor, your specialist you're seeing, you need a new doctor. So, in terms of letting the patients know, you have the right to request a second opinion. I myself, I'm part of a very large team, and we have other specialists. Patients can request a second opinion from someone else within that orthopedic or podiatric or vascular team, or they can request a second opinion from another specialty group if it's possible. And I think we have to continuously remind patients there's nothing wrong with a second opinion. Amputations, once they're done, you can't undo them, unfortunately.
I
Yeah, exactly.
also agree. I think it's a rule of thumb that anytime you're recommended to have any kind of operation, you
Yes.
should ask for another opinion. It doesn't have to be as dramatic as an amputation. And if the physician is offended, they're not the right doctor for you.
I
So
I
I think,
couldn't agree more.
yeah,
We need to empower people. Michael, as someone who's sort of lived through this, what are the thoughts that might have gone through your head, or what do you wish might have happened differently?
Well, I have to curb myself on some level. First of all, as far as people's perceptions of physicians, unless they're educated enough or have a medical advocate, they're going to normally accept what the doctor has to say, and they very rarely question it. Those, forgetting about the doctor on a pedestal, but those days are not much different than they were a long time ago. As far as alternatives are concerned, one of the alternatives that I did go through was a hyperbaric chamber, which worked on one level. It did close the wound that was the result of a catastrophe of a number of service providers that really had no idea what they were doing and how to deal with it. Whether it was a podiatrist, a vascular surgeon, a wound specialist, even a plastic surgeon, they just kept on deferring like a circle because they had never dealt with anything of what I had. And they really had no idea what to do. It wasn't until ultimately I ended up with a vascular surgeon who read me the riot act about the fact that if I didn't do something because of everything that was happening, that I would have lost the kidney or had a cardiac event. But there are options. Hyperbaric chamber I thought was a wonderful thing for 6 months. Just so happened that I was already past the point of really getting fixed by that time.
And so, Michael, what I'm taking from your and thank you for sharing that story, is getting the right healthcare professionals involved. And then what we're hearing here is if you walk away, and I think each of you has sort of said this, if our audience walks away with any one message, if anyone ever tells you or a loved one you need an amputation, you should feel empowered by all of us to say, I would like a second opinion. Now, there are rare life-threatening moments where that may not be possible, but they are
True.
rare. Uh, these types of things typically have a few hours to be able to identify a second opinion. So that's good. Let me get back to another point that was made. This idea of people delay because they don't feel pain. So, Dr. Dove, what is that about? Oh, why do people not feel pain?
So, one of the later complications with having diabetes for a number of years is that diabetes, that elevated levels of sugar in your blood, will attack the nervous system. And you'll see it typically in the fingers and the toes. And it's a very slow, insidious thing that happens. Patients are frequently unaware of. The patients are really only educated when they come in, if they're lucky enough to be plugged into having a podiatrist or a really good internal medicine or family practice doc who will test for their sensation. But a lot of times in the emergency room, when I see patients who are coming in with an emergency with a diabetic foot ulcer that's infected, sometimes they have no idea they have diabetes. And that's an example of how slow and how insidious that these problems can creep up on you, that you may not even be aware that you have neuropathy or diabetes. And the initial symptom is a diabetic foot ulcer, unfortunately.
Yeah.
Michael brought up something powerful, though, about vascular disease. And so many times the deciding factor in an amputation has to do with circulation, although sometimes it's because there's not enough tissue left to close. The heel is a particularly bad place for that. I think that's might have been part of Michael's story. But most of the people that have vascular disease, hardening of the arteries, restriction of artery blood flow to their feet, have heart disease. And one of the big mistakes we can make is getting so focused on the feet, we forget that they need a cardiologist to look at their heart.
Yes.
One of my defining moments as a young physician was working on a patient's foot, and he died of a heart attack in the hospital parking lot. And that, boy, you only need that to happen to you once before you make sure for the rest of your career that you get the right people involved to evaluate that whole cardiovascular system. If you want to, later we can talk about screening, but the fact that he had vascular disease that wasn't diagnosed until he got to a vascular surgeon is a really sad story because it affects the vision. It's the reason people lose kidneys. There's just so much else that is happening simultaneously with the problems that the legs have.
Yes, and so the idea being that vascular disease can attack different parts of the body, and just like you said, um, not appreciating someone that had disease in the legs also had heart disease. We see the opposite quite often. People that have heart disease and they probably have poor circulation in their legs as well, but that's not checked. And then when they develop an ulcer, it doesn't heal and all of the things that develop. So let me just get back to, so I want to think, for our our listeners, so I may not feel the pain, right? And so what can I do to avoid an amputation?
Observance.
Yes, an observance of what? What do we want people to?
Basically, I mean, granted, before the amputation, I did have neuropathy after the years of diabetes
Yeah.
in both areas, as Dr. Dove mentioned. But whether it was an anomaly or not, the ulcer was incredibly painful. I was told it was in the worst place it could possibly be on the body because I'm constantly stepping on it,
Mm.
which apparently didn't help any.
It's hard to heal if you're stepping on a wound,
That's
right?
correct.
Yeah.
No matter how
Yeah.
many lifts I put there, cushions, or anything else.
Yeah.
The only thing I didn't do was put marshmallows in my shoes. But the issue is that you have to, one, know your body, know if something's out of whack, if something doesn't feel right, and do not be afraid to ask.
That's very important. And Dr. Dove, you mentioned sort of people looking at their feet, and what do you want? What should they do, and how often, and give some guidance there.
So one thing that's really important that I think that we have a lot of our complications where we put a lot of burden on the patient. I like to have the entire family or friends or whatever network they have. It's really hard for some of our patients to actually look at their foot, to even touch their foot. If there's a neighbor or a wife, the children, let everybody be involved in it, or a home health care nurse. And really, I think as providers, I know that we're very busy, but I think we have lost our way and we're not as diligent as we should be about really just taking 2 extra minutes in an exam to say, listen, looking at your feet in the morning and at night, or when you have new shoes, that can be the difference between you keeping your feet or having an amputation.
And if you're going to your endocrinologist to get your blood sugar checked, you should take your shoes off.
Absolutely. So, one of the things that I tell my patients is, yeah, take your socks and shoes off, and that will be a reminder to your healthcare professional to take a look at
Right.
their feet, because they'll notice right away you're barefoot. What's going on? Well, yeah. So, one of the other things that maybe one of you can
Shoes.
comment on, sometimes people, you mentioned they might be overweight or have trouble seeing the bottom of their feet, and what can you mirrors?
Yeah, they have a lot of little mirrors on sticks. They're just a lot of really clever things that can allow a patient, assuming that you've got good vision. But I hope Dr. Dove will talk a little bit about footwear, because that can be, one of if we're thinking about the missed opportunities map, most amputations begin with some kind of a foot ulcer, a wound. And there are slow moving train wrecks, as you mentioned, with very few exceptions. There are often months of time that goes by. I'll borrow a phrase from the dentistry. Dentists have a term they call supervised neglect. And unfortunately, that is what Michael was describing, supervised neglect, where lots of people saw him and did nothing because they didn't know. Whatever the excuse is, it's very scary. But prevention is a huge missed opportunity, and footwear is part of that. And that's her area of expertise. So I hope she'll talk about shoes.
Shoes are so incredibly important, and it's somewhat amazing that we've only relatively recently had the ability to give our diabetic patients shoes, but shoes make the difference. Making sure that they have custom or just the appropriate extra depth shoes that are not going to cause an ulcer, and also explaining to patients the importance of shoes for many reasons. Number one, if you have a diabetic who's had diabetes for a long time, they frequently have deformities, whether it's a bunion or a hammer toe. Wearing the improper shoe, even to a wedding or to a special event. It's those special events, they have a pair of dress shoes on. I think it's okay. No, no, no. It's our job to say, you've got to wear those shoes all the time. I don't care if it's the quinceanera or the wedding or the bridal shower, whatever. Wear your shoes and protect your feet. And also be very careful about what shoes you do wear. If you have neuropathy, those shoes need to be approved by your family practice doctor, orthopedist, podiatrist, vascular surgeon, to make sure that you are not setting yourself up for having an ulcer, which we know ultimately can many times lead to an amputation if it becomes infected.
Absolutely. So
Yeah.
checking your feet is key, and having the proper footwear. Now just elaborate a little bit if you don't mind. So proper fitting shoes. How does the neuropathy fit in there?
So patients with neuropathy, they tend to like shoes that feel very snug and very tight. When you have neuropathy, you don't get the signal from your feet to your brain to let you know where you're standing. So the balance isn't affected. And also the feeling, you want more feedback. You like a tighter shoe. Well, that's the opposite of what you actually need. A tighter shoe, you may psychologically feel better and more stable and more protected. But the feet, it's a big problem because it can take maybe 2 to 3 minutes to get a blister shear where we have two surfaces rubbing. This blister develops into an ulceration, and then unfortunately, the patient is set up for months and months of wound care, disability, loss of work, just from a pair of shoes. And unfortunately, I see that day in, day out. Patient says, I went to a wedding. I really had to wear my special pair of shoes just for that 1 hour. And 1 hour, they pay for it, unfortunately, months and months and months of wound care and
Yeah.
sometimes amputation.
So I'm mapping this out as you're saying. So it's sort of having neuropathy. You don't feel that they're uncomfortable, and you actually want them too tight. You develop a blister. The blister eventually becomes a wound, and now you're in big trouble because the wound doesn't necessarily heal. You end up seeing Dr. Fife for wound care,
Yeah, yeah.
and that just gets worse. And then if you have um, peripheral arterial disease, that this idea that the blood flow to the legs are not well, oh boy, now you really don't heal.
And you have the perfect storm. And there are a lot of patients who will think, okay, the shoes are a problem. I'll just wear my socks around the house. And
Yeah.
boy, I know Dr. Deb has seen as many times as I have tacks in the foot, needles in the foot,
Yep.
earrings in the foot, the things that you could step on around your house, and they think they're doing themselves a favor because they're not in shoes that are too tight. And then disaster strikes, even with people who are the tidiest housekeepers. So walking around in your socks is not the answer either.
Yeah, Michael, I see you nodding on a number of these things. That it
Well,
sounds like.
between the two physicians, I'm thinking to myself, you'll show up at a wedding or communion in a cast with crutches, but God forbid you show up without shoes that really don't match. I mean, it's ego and vanity compared to common sense. I mean,
Yes.
come on.
Which would you rather
You're not
do,
going to end up
right?
on Joan Rivers, fashion don'ts. Forgetting about the fact that she already passed, but or her daughter. I mean, come on. I mean, like I said, it's just education.
Yes.
The human condition is so off the rails. But that's
Well,
just my
and
critical
that's
view.
exactly why we're here, to be able to make sure people understand what they can do to avoid. Let me ask another question. So it sounds like neuropathy is a central piece here. Poor blood flow is another central piece. How can someone with diabetes know if they have neuropathy?
I'm going to give that one to Dr. Dove.
Okay. Well, I had the privilege of training here in San Antonio, which is in some ways the epicenter, as Dr.
Yeah.
Fife knows, of diabetic foot. A lot of the limb preservation literature comes out of here. So we've got very simple, very easy, inexpensive tests to do. And the most common one is we take a monofilament, which looks like a little piece of fishing line, and we test 10 sites on the foot, each foot. And if you can't fill the majority of these sites, and I actually think if you can't fill one or two, I put you in a high risk classification to say that you have neuropathy. Because even if you can't fill 1 point, that 1 point, whether it's on your great toe, that's where you're at risk to have an ulcer. And these tests take maybe 2 minutes, and anybody can do them. The family members can be trained. all of the specialists, internal medicine, family practice, vascular, orthopedics, simple, very easy, and validated.
And can I add, really, people should feel comfortable asking their primary care provider to do this test, because every primary care provider should be able to do this test.
Yes.
And it's quick and easy, and it really is you know, the American Diabetes Association publishes the standards of care that sort of describe what should be the routine care for everyone with diabetes. And of course, having a monofilament test, and that's the word, monofilament. It's a small wire-like thing pressed at the bottom of your foot. Everybody should have that done at least yearly to be able to detect any kind of issue. So
By the
yeah.
time people are seeing me as in a wound center, it's too late. But I'd
Yeah.
like Dr. Dove to talk a little bit more about why every diabetic patient needs a podiatrist, because they need to have special nail care. They shouldn't be going to the nail salon to get their nails trimmed. And there are lots of things that are prevention that we haven't even touched on, but that's why you want a podiatrist who's trained in prevention.
And I tell my patients, because sometimes they'll come to see me and they say, I'm not sure why I'm here. I have diabetes. Why should I be here? And I say, wherever you are along your journey with diabetes, whether you're newly diagnosed or you've unfortunately suffered from an amputation, we need to have a treatment plan for you. Just like you go to the dentist for dental cleanings, you come to the podiatrist so we can stratify you, put you into a risk level. If you're somebody who has good circulation, you feel you have no neuropathy, maybe we see you every 3 months, every 6 months, every year, depending on your needs and other conditions. But when we get to the higher risk patients who have some level of decreased circulation, poor blood flow, and neuropathy, those are the patients that we keep a very close eye on. We see them routinely every 60 days, depending on where you are, or 3 months, in terms of what Medicare will cover. And we determine we're going to keep a very tight eye on you, and we can try to prevent things. And God forbid you have a problem, then you have a person to call. You're not going to end up in the emergency room where you may have a higher chance of an amputation.
And so really an ounce of prevention here is worth so much. And being able to know where you are on that risk level, and then be treated accordingly. Uh, we've hit upon a lot of different things here. Um, and a lot of this is in the missed opportunity map. There are literally many opportunities to stop the amputation, from the very end, where you could get a second opinion when someone says you need an amputation, but all of the steps before. And that's what this map that the American Diabetes Association is releasing tells you, where all the different places you can avoid an amputation. I want to give each of you perhaps a chance to make, if you imagined a billboard that people with diabetes would see, what would you put on that billboard? Michael, what would you say?
That's an excellent question, and not an easy one to answer.
Uh,
For a couple different reasons. First of all, you put up someone who's gone through tragedy of some sort. People aren't going to pay attention. On the other hand, if you try and educate them, most of the time Americans don't pay attention to it either. So it's very difficult. I think
well,
that.
what's the message that you would want people to have? What do you think are the important messages that people
Well,
should
I
know?
guess it's sort of the same thing I do with many of my clients' kids, because they don't listen to their parents, but they would listen to somebody who's actually gone through it, even though they're young.
Yeah.
And I tell them, everything that you do today, it's a chronic disease. So it never forgets. You may think it does, but it doesn't. And it will always come back to get the price paid. So whatever you do today is going to have an effect tomorrow. Tomorrow may be 30 years from now, but whenever it happens, you're not going to want it to pay. You do not want to pay the price regardless, especially since nowadays there are so many other alternatives to lifestyle changes than there were 40 years ago. You can be compliant and still have a full active life without any issues. Now, granted, anything can happen at any time, but if you're first to take responsibility of your own health, you've got no one to blame but yourself, and you'll be able to move forward as long as you're compliant with what you need to be. No different than if somebody goes for a pedicure and they have a small little tiny scratch that they don't even notice is there. And all you need is one piece of bacteria, I guess, to get in there. And the next thing you know, you got a problem. I think it all comes down to education. However that's laid out, however you get people to actually listen and understand.
Well, thank you, Michael. Dr. Fife, what parting?
Remember years ago when Bill Clinton said it's the economy, stupid? I think the billboard I would have is it's the diabetes, stupid. I don't want to sound like I'm criticizing patients, but neuropathy happens because blood sugars are out of control and stay that way. And all of the other things that get out of control, like weight, the heavier you are, the harder the life of your feet. So they're just, it keeps coming back. When we look at the prevalence in the South, Dr. Bob, I have a hypothesis that the ADA needs to test that I'd call the sweet tea line. As you drive from, east to west across the South, the point at which you don't have to specifically ask for unsweetened tea. When the tea is automatically sweet, I want to know the answer if that's correlated with the increasing likelihood of amputation. So yeah, I'll let you do that research, and you don't have to credit me that there is a sweet tea line, but it is the diabetes. That's the disease. So we do want to make sure if somebody gets a boo-boo, I don't care what you call it, if you have a red spot on your sock, then you're headed down the path to amputation. So I tell patients, wear white socks and look at your socks to see if there are spots on your socks. That's a great early warning sign, but it's always going to be about the diabetes. And like Michael said, it's often years later, and we're none of us very good. Maybe he's better as a CPA because CPAs understand planning for the future, but the rest of us are not so good at thinking about the future.
Great, thank you. And Dr. Dove.
I think I would do something along the lines of build your team. You need to have a team around you, your family, your friends, and also every doctor that you see. We know that if you're diabetic, you're going to at the bare minimum, have a primary care physician or healthcare provider. But maybe if you're lucky, you'll have an endocrinologist, you'll have a podiatrist, you'll have a cardiologist, possibly a vascular surgeon. Every interaction with the healthcare provider or with family members, if you can't do it yourself, somebody should be looking at your feet. Because if we can catch the pathology, the ulcerations or pre-ulcers early, we can treat them better, as opposed to someone coming into the emergency room with the limb and life-threatening infection. So early is better. That would be my second slogan, early is better.
Early is better. Yeah, absolutely. Especially when we started off by saying 80% of amputations are preventable. So there's so much that can be done. Well, I want to thank each of our speakers for joining us today. This has really been a robust discussion. And I want to encourage you all to check out the missed opportunity map that is on the American Diabetes Association website, diabetes.org. You'll see a place to go to the amputation prevention site, and that missed opportunity is your chance to make sure that you don't miss an opportunity to prevent an amputation, because we know they are preventable, and we don't want anybody listening or anyone to have an amputation. That's what we're driven to do. So thank you all for joining us, and once again, thank you for our excellent speakers.